who is an associate professor and assistant dean of equity and diversity and inclusion with the University of Maryland School of Pharmacy. Dr. Whittaker is a board certified geriatric pharmacist with a focus on increasing medication literacy and health communication in older adults and an emerging expertise integrating anti-racism pedagogy into education, practice, and leadership. She has practiced in a number of team-based ambulatory care clinics, providing services to older adult and other patients with multiple chronic conditions for over 15 years. So I'll give her a second to kind of do it, because I had already finished there. Go ahead and do your thing.
I'm just gonna pull up, I had a poll, so I'm gonna pull up the poll here. So, oh gosh, I'm gonna get on the website. And I don't know if the recording is still on, so I don't know if you want to pause that for a minute. Pause. Again. You're always all right, let's see. Oh, all right. All right, well, thank you everyone so much for continuing to be here this afternoon. And if you give me one more minute, I realize I have my polling questions on my saved slides. Yeah, I have them under mine. So I think I can open them up through OneDrive. So if you would be patient with me one moment, I'm going to open that up. Yeah, because I think we can get to OneDrive through the website, right? Faculty, let me try this way. That's curious. It's okay. All right, is that me? That is me. Is this the, oh, that's you. No, hold on. Let me. Add maybe? Okay, different account. I'm like, what is that? Oh my goodness.
So if you go back into this one, oh,
okay,
there you go, perfect.
Okay, using that one. All right. All right, then OneDrive. Okay. Give me a break. Yeah, so there. Okay. goodness. Is there not a way to open it and? Open it. Oh. Sandy, do you know how to open these things online? Download, let's try that. All right. All right, thank you so much for your patience. I appreciate it. I had to make sure I had the right slides, but good afternoon, everyone. Feel like I haven't been in front of a lecture hall in like 2 years. It's unbelievable, but I'm really excited to be here live and in person, and so excited to see many of you live, and also those who are able to join us virtually. My name is Whittaker, as Sandeep said, and I am a longtime faculty member and primarily practicing in ambulatory care and geriatrics, as well as nephrology, where I focus in on pre-dialysis patients with chronic kidney disease. And over the past couple of years, our school has really begun tackling the issues with equity, diversity, and inclusion, and really what does that mean for informing our curriculum, how we train you as emerging leaders, and everything that we do. So over the past couple of years, I participated as a co-chair of our task force for diversity, equity, and inclusion. And I really took that time to do a deep dive. And as you're seeing things in current events, you're looking at things historically. Maybe you've had your own personal experiences to really understand how all these things are fitting together. And one of the things that I really learned as I was doing a lot of research is really asking the question, what does this mean to me as a pharmacist, and how I practice, and what do I need to do differently? So one of the things that I really dived in deep is looking at narratives and how that influences our biases, and then in turn, how that influences how we practice, how we teach, and how we interact and engage with one another. And that is where I will be focusing today. So I have just a few active learning questions. And since it is a hybrid, and also since maybe a couple of the questions that I will ask will be a little bit sensitive, I would suggest that you don't respond through the chat, but actually respond through Poll Everywhere. You don't have to say who you are, just skip through that section, because I would really love to get your feedback. Certainly when we begin talking about issues of equity and inclusion, really everyone being present as themselves is the best way, and giving some real feedback is great. And when I pull up the poll, I'll also share the link again, so you'll have an opportunity to see that one more time. So the goals for my session will be to really look at racism and how it operates through the narrative ecosystem to produce and reinforce health and equity. So we'll look at that. And certainly this is not going to be an all-out discussion on systemic racism, structural racism, but I hope that I will give you enough of a foundation to help you to understand how it absolutely does impact, influence our decision-making as pharmacists. The second is we'll look at several examples of a patient-provider interaction in a clinical setting, sort of looking at it through 3 lenses, right? Patient-provider engaging, maybe talking to a provider, then how we document information, and also how we use clinical practice guidelines to guide our decision-making. So we'll look at it through those 3 different snapshots. And then lastly, and very, very important, what are the strategies that we can use immediately today, tomorrow, to begin to interrupt and replace stigmatizing or racialized or other oppressive narratives, and replace it with equity-based and race-conscious practices? So I think as we begin to talk about topics such as racism, I think we do need to establish some community guidelines to make sure that we're doing this in an honest but respectful way. So I certainly invite you to be present. So, I know sometimes you get a little message or anything, totally respond to that if it's important, but try to be present as much as possible, particularly when we're having our discussions, because I absolutely want to hear your feedback, because I want everyone to hear your feedback. We all come with very different experiences, and that is so critical for us learning and growing, right? So a little discomfort is totally fine, and I think it's an important place of growth. I invite you to listen actively, which means empathetically and curiously. It doesn't mean your experience is my experience. It means I have been maybe silenced sometimes, right? I have felt like I was not taken seriously, right? So empathizing doesn't mean we had the same experience, but I may have had a similar experience as a human being, and I can listen on that level to your unique experience and value that. I invite you to speak from your own experience using words like I, me, my, instead of they, we, you. I don't know who they is. It would be very important for you to focus your comments on your experience, what you have seen as you have been practicing. And although no one, in one experience or example is proven to be accurate 100% of the time, we'll try to hear the truth in what is said instead of looking for examples, exceptions, judging, deciding it's not my experience, so pretty much it's not valid. And lastly, we will assume that everyone is well-intentioned in what they're saying. However, we also understand that in these sometimes charged conversations, there can be something that said that is hurtful. We acknowledge that there can be impact in the things that we say, but again, if we're practicing with a sense of honesty and being respectful, even if it does hurt someone in some way, I think we can work our ways through that. And with that, I will begin after laying some ground rules. And one of the things I was thinking about as I was putting this discussion together is really, conversations that we avoid, and it's racism. You're going to hear that word a lot today, right? As I'm speaking to you. And we've almost been conditioned to not talk about it. Let's pretend like it's not happening, right? We don't talk about Bruno. We don't talk about racism and slavery. And we definitely don't talk about Jada. Y'all got that one? Okay, so, but anyhow, so things that we don't talk about, but I think it is critically important that we talk about it. To one, learn what is it and what it is not. Some of the narratives that you might have heard about racism is that racist person over there that's got a bad attitude, but I'm a good person, so this has nothing to do with me. That is a harmful narrative. It is not accurate, and it doesn't help us to move to a place of equity. So one of the quotes that I absolutely love from Ta-Nehisi Coates, he has done a lot of work in this area, and he's a great journalist, and I put a reference at the end. And one of the quotes he says that I think seemed crystal clear to me, he says, but race is the child of racism, not the father. And the process of naming the people has never been a matter of genealogy or physiognomy so much as one of hierarchy, right? So racism uses race as part of a racial hierarchical system. And I'm going to keep using the word system, right? Because again, we don't want to place it in this person and that person, but it's a system that we all operate in, because it's been a system that unfortunately this country has partially been founded on. So it's something that we have to contend with in all of the organizations and things that we have worked in. So in this slide, what I really hope to illustrate is that there are different levels of racism, and they're always interacting in different ways. One of the biggest things to learn about racism is whether you decide to participate or not, it's a system that will continue to go on. And actually it works better when you just go with the flow, right? And it just continues to move along. So if we do nothing, it will continue along the way. Another thing about racism is that it is quite invisible, right? And in your experience, if you've never experienced it, you're thinking, well, I think everything's fine. We're totally post-racial, nothing's happening here. However, we have to think past our experience and understand that people are having other experiences, experiencing the same sort of event. So I like to think of it as gravity, right? That's the word that I'm looking for. Although we may not see it in action, it's still certainly in action, and it's certainly still a reality. So we're going to focus in more on the interpersonal aspects, but understanding that interpersonal interacts structurally, societally, institutionally, because it is people who develop policies, right? It's people who run institutions, who are on boards, who write clinical practice guidelines. So what they believe and what they understand is critically important to how our institutions are developed and run and how our patients ultimately are impacted. So another way that I, like to think about and bring our awareness to racism is through, again, our experiences, right? I would imagine that if I asked you to share all of your different stories, if we were a smaller group, I'd ask you to do like a parent share and share who you are, right? So I'm a faculty member, I've been here for 15 years, et cetera. However, I am, Chanel Whittaker. My parents, my mother is from the South, my father's from South America. I grew up in New York City. And it was actually in a pretty racially segregated neighborhood. And it was like a planned community, but in a negative way, right? This is where all of the people who were considered undesirable for other neighborhoods in New York City, we've kind of shuttled in these parts of town. And it was part of racialized segregation. And if you've heard of it, redlining, and I put some resources in the back, that is part of my story. It's very complex. However, now, although I grew up in a situation that was segregated, lack of opportunities, now I have lots of opportunity, right? I am very privileged. I speak English very well. I have, enough money to take care of my family. I have insurance. So I have very little concerns compared to someone who may be in a different situation where they do not speak English very well, right? They are not insured. We have very different experiences in this world in the healthcare system, just based on our different experiences. So I do want you to understand, although we're talking about this on a very basic level, we all have very nuanced experiences, and it's important to think about all people like that, including our patients. So this quote here is probably something that you'll hear a lot. We all have biases, and I love the quote where it says, if you say you don't have bias, then I think your brain's not functioning correctly. It's important for our survival that we do have bias, but I think that we have to also be responsible for that bias. Although it is functioning on a level where a lot of times we're not aware of it, we should examine how it is impacting or influencing the way that you're making decisions. And if it is negatively impacting a situation, it's something that we can actively seek to change. So one concept that I'd like to share as we talk specifically about narratives is narratives and the way that we grew up culturally, what we understand about what's good, about what is right. All of those things go into who we are as people. And although now we're all pharmacists, it will impact how I might make decisions slightly differently, or I may treat one person slightly differently because I resonate with them or I understand where they come from. We all are going to behave a little bit differently because of all the different ways that we are as people, right? We're very unique and beautiful and everything, but we have to understand that we're all going to be different. However, our biases certainly are shaped by how we were developed, the narratives that we learned in our family, in our community, et cetera. But also it is the narratives that we hear that are sort of incoming. You have social media, you have the news, and now you got lots of politicians. I see signs everywhere, right? Vote for me, vote for me, vote for me. But they all come with a narrative, right, to get you to vote for them. So there are narratives that shape what you believe, right? And it begins to elicit a certain behavior based on how you connect or do not connect with that narrative. And when we have these deeply seated narratives that we have learned over time, we act on it externally based on how we perceive a situation, right? So I'm thinking that how many of you are sort of coming to Maryland, to Baltimore for the first time? Okay, lots of people who are coming here for the first time. So I would imagine that based on where you've come from, right, you may perceive maybe what you see, a little bit differently than someone who's kind of grew up here all the time. So we're all being shaped by these different influences and narratives, and I'm going to ask you a little bit more about that in a little bit. So one of the core guides and references that I use for this content is the American Medical Association's Guide to Narrative, Language and Narrative Concepts. They do a really deep dive on deep narratives and how it shapes us as clinicians in making decisions, and how do we get to a place where there's so much inequity, right? Now, obviously, it's not just because of a decision you or I are making for a patient on a day-to-day basis, but how that absolutely influences how we develop health and equities among different people groups. So one of the examples of a narrative ecosystem that they give is messages that you've had when you're growing up, maybe in your community. And then that goes along with stories, right? So a story might be an experience. A story might be a news story that you heard on television. It may have been an influencer, right, that you listen to often, developing stories. And then a narrative is really, and I'll read it, it is a collection of stories and messages that represent an idea or belief, right? So for example, if you work hard, you'll go far in life, right? It could, just a simple message, but over time, if you have that experience reinforced, I'm working hard and I'm making it places, right? And it makes you believe that, well, that is a narrative that I believe. It highlights our values, but also it defines problems and causes and determine solutions and actions, right? So if you decide, well, maybe I'm not doing well in school because I'm not working hard enough, right? So, and again, it may be based on that deep narrative, well, if I work harder, I'll do better. But maybe there are people who have different experiences and they're working really hard, right? And they're not doing any better. So someone's perspective and someone's narrative based on the experiences may be different. And over time, we have these very, very deep narratives that you don't really think about it, but it is expressed in different ways and in different situations. Now, in the context of how this begins to develop inequities, both in society and what is very pertinent and relevant to us as pharmacists and in the healthcare system, is that these narratives influence our biases. And this, together working with a system of racism, can really begin to cause these inequities. So I put a quote here from John Powell. He is really a thought leader on othering and belonging, and he has lots of resources on his website. But again, as I talked about, we get these messages and stories that we hear on TV, social media, et cetera. And that begins to, those people who might be, developing who have these ideas might be developing histories, policies, practices. So for example, things that matter like voting rights, right? I talked about racial segregation, and also that also has a lot to do with access to education, healthcare access, et cetera. And then this can lead to inequitable outcomes, because if you see someone who is constantly getting arrested on the television, and it's like, well, we have policies for people who are doing the wrong thing, and you get arrested and it's always the same people, you may begin to believe, well, they're just a dangerous person, and dangerous people belong in jail, right? And that might be a very deep narrative, although you have no problem with the person sitting in front of you, but that deep narrative may cause you to treat that person differently based on that information that you had learned over a long period of time that's just simply very deep and baked in. So for those of you who are just coming to Baltimore, what have you heard about Baltimore? Who'd be interested in sharing that? What have you heard about Baltimore? I'm very interested. Very dangerous, right? Baltimore is very dangerous. So also that leads me to say that narratives are not only about people, but you can have narratives about places as well, right? So Baltimore is dangerous. What else have you heard about Baltimore? Come on, tell me. We gotta be honest here, right? Because you're going to see patients like tomorrow, right? So these things really do matter. What else have you heard about Baltimore? Anyone? I don't know if anyone's on the chat, but
the sports teams aren't that great.
Oh, sports teams aren't that great. I don't know nothing about that, but okay. Sports teams are not that great. Any other things that you heard about Baltimore? Yes, please. The Wire. Oh my goodness, yes. Absolutely. No, I love that you brought that up, right? And I was actually at a talk yesterday and someone said that was the immediate thing that came to her mind when she was coming to move to Baltimore. Now, oh, and I see something. Let me see if I can attempt to open this up. People are leaving. Oh, no, hold on. People are leaving the city. What is that? People are leaving the city. Okay, so that's some of the, oh, right. Yes, so I've heard that on the news too. People are leaving the city. Now, how about people who have lived in Maryland and lived in Baltimore? What do you know about Baltimore based on your experience? Is this representative of your experience? The Wire, danger? Yes, please. Right, absolutely, right? There are more than murders that are happening in Baltimore, right? So when we hear these narratives, right? So when you get here and you're practicing and you're working with a lot of people in the community in which these narratives are placed on, right? You think, oh, maybe this person has a tattoo here, they got a few rings and piercings here. Maybe you might make that connection, right? And then you decide very unconsciously, this person deserves or doesn't deserve, or this, so it's really important for us to examine what we believe. You're here to take care of people, right? So the way that you believe and think about them absolutely matters, right? It absolutely matters. Just as if someone is coming to care for your family in your community. So, all right, yes, a beer town with a baseball problem. That's funny. And entrepreneurism is thriving, right? So there's so much more to the narrative than just those, clips that you hear, right? So if you hear a politician, it's like danger, danger, crime, danger, vote for me, So it turns into that deep narrative. They don't even need to associate it with that message. But again, the ongoing message might be in Baltimore, it's dangerous, it's a lot of crime, right? So now as a politician, all I have to do is danger, danger, this person's doing a bad job, vote for me, right? So I think, again, extremely important. So one of the things along the ways of, dangerous, I would say dangerous narratives, particularly around Baltimore, is the Baltimore Sun, and you can look this up. This is actually put out in February about how the media, particularly the Baltimore Sun, for about 180 years, I believe they've been in print, they acknowledge that they have contributed to promoting oppressive policies through the narratives in the media about Black Marylanders. And they say they're working to make amends. So it's a few things I really like here. I pulled them up is because they acknowledge, their role as part of that narrative ecosystem, but also they're working to make amends, right? So again, just saying, I'm sorry, that's great, that's wonderful. However, we have to work to move past that narrative and recreate a new narrative that is more accurate and favorably represents in this case, all citizens in this community. So thank you for sharing your experiences there. And Baltimore is not the why. It was like one show, right? Like one show, but whatever. It will live in infamy forever. So, I come to this part, basically to say, we have to really think about, as professionals who part of our goal is making sure that our patients get the best of care, we have to acknowledge and be mature and acknowledge the way that I have experienced life may be different than the way that they've experienced life, but that can have a significant impact on the level of care that they receive. So one of the images that I'll leave you with is looking in the mirror, what might be my biases. I think this place is dangerous, right? So if you go in every encounter, oh, danger, danger, right? So really thinking about that and examining, where did you get that from? Is it all from the media, right? Have I met anyone that was so dangerous? Really examining that, interrogating that. But then also what do I see when I look through the mirror, through the window, right? So in the mirror and looking through the window, what do I see? How do I perceive that situation? When I see the homeless people in tents on Martin Luther King Boulevard, how do I perceive that? Are these people lazy, right? They should have worked harder, right? That might be a deep narrative. Or if we're thinking more globally about society and the structures, right? And I see everything through the lens of anti-racism now, I'm thinking maybe, they were under-resourced as a community, right? And when you're already on the margins, it's really easy to fall off, right? Gas prices are going up, housing prices are going up, very limited opportunities. So I always try to see things through the anti-racism lens. So really thinking about mastering your stories and what are you seeing about any given situation, right? Because your mind is always taking snapshots and really evaluating critically, how am I thinking about and how am I going to choose to act in this situation? Oops, let's see. Okay, so I am going to do one of these videos, and I know I overdid it with all the examples, et cetera. And this is not working, are you kidding me? Okay, let's see. And I'll try and do this correct. So this is an example of a community pharmacy interaction. This is the pharmacist telling the story, and I just want to play an excerpt of it a little bit, and then we'll move on to our next activity. But as you're looking at this, again, we're looking at the patient-provider interaction. One, what messages, stories, and or narratives are you hearing that the pharmacist is expressing through the action towards the patients? And also, I put a thing in here on self-reflection, but I'll put that there. But I'll skip to the third one. So what message, stories, and narratives do you hear the pharmacist expressing? And then the third bullet, we'll come to the second later, how do these incidents of harm shape a patient's perception of this healthcare system, and how does that impact their health behaviors, right? So we'll try and look at one of them. Hopefully YouTube will. And please don't show. I'm sorry. A little levity. And I just want to make sure everyone on the Zoom can see, because I didn't reshare or anything. So I just want to make sure that's okay. And see and hear. I'm going to go to, and I'll just play the first part. And I will stop it there. So as you kind of looked at that, his experience, what messages, stories, or narratives do you hear, from his story of the pharmacist and their actions toward the patients? Now, obviously, we can't imagine what they're thinking, but in general, based on the impact, what do you think? Yes, please.
I think just based on how the story was presented, it makes me feel like perhaps the pharmacist didn't value that patient population as highly and didn't feel as upset by providing them a suboptimal prescription product.
Right. So the pharmacist didn't seem to value, right? We can't imagine what the person was thinking, didn't seem to value, but by their actions, it suggested, that the level of care was casually lowered for these patients, for this, particular child, and he was kind of okay with that, right? So any other thoughts? Let me see if I can pull up the chat here. Hold on. Oh, so sorry. Oh, okay, my apologies. Okay, I apologize. And it was the first 2 minutes of the video. So any other messaging that you heard there? What about the differences between how he was treating the customer versus how he was treating, I believe, the pharmacist, the pharmacy intern at that time, Marvin? What do you think about that? Yes, please.
I thought maybe it could have been more like possibly a socioeconomic thing, because it seems like he was doing well as he was like an intern working. But then again, the pharmacist doesn't know these people and he doesn't interact with them, so he can't make that assumption, but I think that he probably was.
Right, so he could assume maybe, Marvin had made it out and, therefore he's okay. But, I think, again, one of the big points of this story is that our biases, whatever we believe about people, if it is causing a disparate impact on them, that's the point, and something that, we have to make sure that we're examining, because it can cause us to do some things that are not helpful, but then, on the extreme end, actually quite harmful. So how do you think, this incident of harm, or incidents of harm that patients experience, can adjust people's perception of the healthcare system and their health behaviors, right? So what might be the impact on the patient? Yes, please.
That they simply not seek care because they don't feel that they're being heard.
Absolutely, right? If you don't feel like you're being heard, you don't feel like you're being treated well, you just won't go in to seek care. Yes, please.
As the intern in that situation, he probably walked away potentially not feeling safe or welcomed in that work environment, and that could deter people from continuing to go into the field.
Right, and I love that perspective, right? So not necessarily from the patient's perspective, but from the trainee's perspective. Like, I kind of went in this to help people, and it really does kind of adjust how I feel, whether I feel safe around this pharmacist that I'm really learning from. So I really do love that perspective. Thank you for sharing that. And thanks, to all of you, but, I'll leave you with this question, not that you have to fill in the blank, but again, what messages, stories, narratives about, your patients, and I say that very broadly, about people like them, have you heard or might believe, the places they live, socioeconomic status, and how can that impact patient care? Right, and I'll leave it at that, not that you have to answer it, but it's maybe something that's in the back of your mind as you go along with your day-to-day. And one of the biggest points of, really thinking about narratives and all that is like, well, who cares? Why should I care? Because there is an impact, right? And although maybe that pharmacist, I'm going to say, didn't intentionally mean to cause harm or deliver suboptimal care, it doesn't matter what the intention is, right? It's nice to have a nice intention, but if the impact is negative, right, in patient care, then that's where we need to focus our attention. Sometimes I believe we begin to focus on it. Well, she didn't need to, they're really sorry, but the impact, we have to make sure that we're focused on the impact and working on getting our intentions in line with our intended impact, right? So adjusting maybe our intentions, doing some examination there. So I'm gonna go through very quickly because you can, totally look at this afterwards, but I just pulled out a few examples now of looking at stigmatizing language and communicating bias through the medical record. And this study was actually put out in late 2021. And the authors really just looked at how language was being used. And I love this article because it reflects a similar academic medical center that we have at the University of Maryland Medical Center, the VA. So very similar scenario as we might be here in Baltimore City. The patient demographics, I don't know, what the demographic is racially, but a high amount of African Americans and a good sampling of white patients. And it basically looked at overall themes. Was it a positive theme or a negative thing? It didn't pose any judgment about what they thought about what the people said, what they said in the note. They just categorize them. Is this positive language or negative language? So I'm just gonna let you look at this a little bit, right? I'm just gonna read down the categories and you let me know kind of, what you think about this in terms of how it resonates with you. Have you done something like this, and if you have any thoughts about it, right? So I'm just gonna read down the list. Negative categories: questioning the patient's credibility, disapproving of what the patient's doing, the choices they're making, racial or social class stereotyping, classifying the patient as a difficult patient, and unilateral decision-making. So these are the different categories that they found. So any of these stick out to you that you have seen personally? that you have done personally. I can, raise my hand on a few of these that I have personally done. I used to use refused as a weapon. He refused to do as a patient, refused to do that. I since stopped, thankfully I have recovered from that word. But refuse, it's a pretty violent word, it really is. And it communicates this patient is difficult, right? And that narrative continues to pass down. And now I'm informing other providers how to treat this person, right? So I've recovered from the word refused. And if they refuse, I always have a reason for, okay, well, you're not interested at this time. Can you share a little bit about why you made that decision as an adult with agency? It's okay for people to say no, right? So I'll get a reason if they really say, I'm not interested. I get a reason, right? Anything resonate with anyone? And I see a couple of things in the chat. Chief complaint, please. I don't know if you can go audible, Amy, but can you say a little more on that chief complaint? Because obviously it's something I know we see all day, every day. And I don't know if you can talk, Amy, but if you can't.
I'm in a
great.
hotel lobby, so it might have background music there, but basically I have started having my learners use the words chief concern. I think there's a kind of stigma around the complaint that maybe invalidates why they're coming to see you. And I think that it also has just a negative connotation as a word. And so I would much rather have people phrase it in terms of a concern, because it validates then why they're coming to see you.
Absolutely. I absolutely love that. And so I will also be removing complaint from my vocabulary, right? So whatever I can do to move more towards patient-centered, keeping the patient in the center, I'm going to do it, right? This has nothing to do with me and my comfort, what I feel like doing. It's about how can I get more towards and in line with having the patient in the center of that frame. So I absolutely love that, right? So it really does center the patient's concerns and not saying, that they're, here complaining. So I absolutely love that. Yes, please.
I think on the flip side of some of this, though, I think what we find ourselves doing is trying to find like that ultimate truth of what happened in order to better treat the patient.
Mm-hmm.
And so some of these comments like supposedly claims insist, like I know, there's perhaps easier ways to say that, but I think regardless, it's going to suggest disbelief in what the patient is saying, because you do ultimately want to get to the truth of, did they take something at home, and so that I can better treat them and manage the problems that they're here. And so I think that's sometimes difficult to get around.
Right. So I agree. So sometimes there is information that needs to be communicated about the patient really doesn't want to do X, right? Or the patient is ready to leave, right, against medical advice. So how do you communicate that in a way that we maintain the patient? I disagree. I don't think it's a good idea for you to leave, but you are free to roam, right? I can't, unless you're under, observation by, police officers, you're free to roam. I disagree, but how can we disagree with the patient's decisions without making them look like this is really dumb idea, right? Of course you don't agree. You need a few more days here, you need IV this or whatever that, but they have made a decision, right? So my question is, how can we say it in a way that maintains the person's agency, right? And in the end, again, you're in the frame, this person's being difficult. But is there a reason that they have to leave, right? I don't know. I'm just throwing things out there to get us to think. I don't know if there's a perfect solution, right? But certainly, for example, when you mentioned supposedly questioning the patient's credibility, often I would get this in patients, I work with older adults and many of them have cognitive impairment, and they would often say something like, I took all my medications. And I'll say the patient says they took all their medications. However, in the chart, it says the last time they filled it was in 2019 and it's 2022. So there is a way to communicate that, well, that's what they said, and this is what I see, right? So there is a way to state that without saying, I'm questioning. Well, in their mind, yes, I'm still taking it, right? So I think there is a way, right? And it takes practice with, communicating differently to think about how can we keep them centered, right? Without it being, okay, now I'm blaming, things like that. So it's just a thought, right? Still working on it, right? So you can just say the patient states, this is simply what they said, right? And that's subjective history. This is what they said. This is what I see. This is my assessment. Yes, please.
I've seen a lot of in mental health, patient was adamant like not speaking to providers or like claims and I see a lot of that, and like, especially in mental health and psychiatry.
Right. No, I love that. Right. And I think in everyone's specific discipline, I think it's necessary to have this conversation. How are we framing things in a medical record? Because it is causing people to perceive a patient in this way or that, right? So certainly if someone is having hallucinations, they're going to claim, to see, Billy Idol. I don't know where he is, but anyways, it's the name that popped in my head, and he's at my house visiting for the weekend. The patient says Billy Idol's at his house visiting for the weekend, right? I don't know. In his mind, he had a visit with Billy. I don't know. But again, is there a way to keep the patient centered, right? With stating the facts and then your assessment. I don't believe Billy Idol was at his house. This is what I think. We need to crank it up on his medications. I don't know. But yeah, so I think you had a hand up there.
Yeah, I was gonna say one more thing. With patients now being able to read their medical records a lot quicker. My parents in particular get very angry when the patient or when the provider says patient declines this therapy at this time, which is something I write all the time. And it's very interesting because now they're not going to certain providers because they don't want to be labeled as a non-compliant patient.
Right.
And how do we work towards better languaging while still covering ourselves through our documentation that we're making a recommendation and the patient is not moving forward with it?
Right.
Kind of a follow-up question.
Absolutely. Thank you, Shelley. And absolutely, it's not just us in the conversation anymore. The patient's in the conversation now too, right? Just, in an academic setting, it's not just us anymore, but maybe the students now could read all the, whatever you say about them, maybe in a, if you're doing an evaluation, right? So it's not just us having a private conversation, but the patient's also included in too. So we should be concerned about how they perceive that. And I'm gonna show you an example of that, actually asking the patients how they feel that they're being perceived in the healthcare system. So thank you so much for that feedback. Again, it was no negative, no positive, it just is what it is. But how can we look and identify areas where maybe we have done this and think about how we can state the facts without adding too much color about, what we think and how we feel about what the patient is doing. All right, so then they also categorize positive language, right? So compliments, approval, self-disclosure, sort of empathizing, identifying with, minimizing blame, personalization, and bilateral decision-making. And these are just, again, we're just categorizing. And I think this is something that I try to do verbally to the patient, right? It's nice in the note, but, especially when someone, particularly AmCare, they've had a disease state, for 20 years and you're still taking your medications, I'm going to celebrate you for something, right? So just encourage a person along the way. And that's just something that I do in ambulatory care. But also we can think about doing this in the note as well, right? So sometimes I'll write, congratulated patient, whatever the word is. Often if there is something good, to identify out of this encounter to encourage a person, I will do it. Not to say that you have to do it, but again, these are some examples and ways that we find in the note where patients might be positively cast in the medical record. So, so any thoughts on this one, on this slide here about positive language? Oh, yes, please.
Yeah, I did want to touch on this a little bit because, well, I'm a PGY1, but right before during my APPEs, I had kind of like a virtual ambulatory care rotation. And we saw the best differences when we were able to empower patients. And oftentimes it was me telling them, hey, I know you've been struggling, but you're doing a really great job. Especially with my geriatric patients who you could feel them light up on the other side of the phone. And so I would say I always try to incorporate this, even if you're a little bit concerned about the patient. Definitely makes a huge difference.
I totally agree 100% that, again, if someone has been working with the disease for 20 years and every time it's get that blood pressure down a little bit more, that cholesterol's too, every time you okay, I'm doing all I can here, So anything to celebrate, encourage, similarly as along your journey, right? We might not be using the sandwich method any longer, but we do want to temper those, okay, let's continue, let's push, with you're doing a great job. This is where you're doing well. This is where we can continue to grow. So I think similarly, we want to be motivational in the way that we work with our patients and also document, right? So that it doesn't create a barrier for them when they're working with other team members. Excellent. Thank you so much for your feedback. Another aspect of language and narrative within the medical record, I think is around, sometimes I believe it's around, it could be a little bit of racism, could be a little bit morality, right? And it was interesting, very cool study in 2018. It was looking at patients with sickle cell anemia, and they really looked at perceptions of trainees and how they perceive the patient and their attitudes about the patient, and then how much pain medications, how much more aggressive pain management they would get. And I think I'm going to say maybe this has been an issue very commonly with sickle cell anemia, but again, our attitudes absolutely have an impact is the point of this slide. But this is on the top, the letter A is the positive attitude towards sickle cell patient scale. Going higher on the scale means you have more positive attitudes. Lower in the scale, more negative attitudes. B is pain management score. 7 being more aggressive pain management, and 2, less aggressive pain management. And what they found was they literally gave 2 vignettes, 2 scenarios. One, they colored it up with a lot of stigmatizing language, and the other, they just kept it to the facts, right? And based on looking at these 2 charts, what they found is that the more stigmatized, neutral language, it showed they had more positive attitudes about the patient. They had more aggressive pain management. Versus the note with the more stigmatizing language, they had more negative attitudes, and they were less aggressive with pain management, right? And so this is obviously problematic, right? Because again, the note has communicated a narrative about the patient, and now the provider has acted on that, right? Through their attitudes, and now that's turned into action, less adequate pain management. So that is absolutely problematic, and it promotes inequities. And I don't know if anyone works in pain. Does this resonate with you at all? But I'll give you an example of a little bit of what they wrote in the note, right? So one was, and this is the colored up language, this person, I don't know if it was person who actually gave any more description, was standing in front of McDonald's, hanging out with his friends in the middle of the day, started complaining about pain and came to the ED. That's pretty colorful, right? Then the stripped down version was the person was with friends earlier this afternoon, was complaining of pain and came to the ED, right? So I think communicating 2 very different things. What are they doing out there in the middle of the day, hanging out with friends in front of McDonald's? Is it your business, right? It's like their person is in pain. That's the point. So anyways, but again, it communicates, right? I disagree with the way you're spending your time in the middle of the afternoon, right? So it's communicating a lot in that narrative. So any thoughts on this? But that was really my main point, that the stigmatizing language and narratives has a definite impact of harm on the patients that we're trying to help. The last snapshot that I want to look into is this study was done a long time ago. And the reason why I chose this study to look at patient perceptions is because it was a really, really great sample. And the study design was really, really on target. So that's why I use this one. I'm sure there are more recent, but this is sort of the gold standard. So there was a telephone survey of Americans in 2004, excellent response rate, for a cold call, 53% response rate. They translated the survey into several different languages, which I think is really excellent as well. So increased language access to the survey, and they oversampled minoritized populations to make sure they had enough to really reflect what the demographic is in this country. So they were able to get a reflective sample of the entire country on this phone survey. So really, really excellent study design. And what they did was ask a few questions, about patient perceptions of disrespect in the healthcare setting. And some example question was, I often feel as if my doctor looks down on me. Do you think you would have gotten better medical care if you belonged to a different racial ethnic group? Was there any time when you had a medical problem but put it off, or didn't seek medical care when you needed to? And lastly, has there been a time when you didn't follow the doctor's advice or treatment plan, get a recommended test, or see a referral doctor? So the goal was to understand what their perception was, and then look at, did that make a difference in healthcare utilization, right? Having a physical exam, chronic disease state monitoring, optimal cancer screening, or did not follow a doctor's advice or delayed care. So what they found was they categorized this into several areas, just looking at each question. But if you look at the different patient groups, so those who did not speak English as a first language, 100% below the poverty level, uninsured, Black race, Hispanic ethnicity, Asian, or white, and they looked at it in those different categories. One slightly concerning thing, which is pretty concerning, is that pretty much all of the participants believe that they were looked down on or treated with disrespect in a healthcare setting. What are your thoughts on that? Pretty much all the patients had a concern with that. I think I saw your hand kind of go up.
Yeah, I was just gonna say, I think it has probably a lot to do with like tone when providers are speaking to patients. So how you sound, even though you may not be looking upset or anything, but how you sound, I think may like kind of put people off a little bit.
Right. So, how we sound and, again, obviously they've had all very varying differences, but this is a concern that, many of the patients felt that they were not being treated with respect. But also looking at treating unfairly because of race, language, and, they thought they were being treated unfairly and they would have received better care if they were a different race, really does show based on level of insurance status, based on race, ethnicity. There were concerns about perception that they were not being treated fairly. And again, it's not just perception, but this also had an impact, right? So there was shown that these patients said they had, sometimes delayed care, suboptimal screening for chronic disease states, or they didn't follow up with their doctor's advice, right? So there is a definitive impact. How much more time do I have? Till 3, I have like 2 minutes, right? Okay, so what I'm gonna do is I'm going to skip down to strategies, right? And I'm all about the discussion, right? So if we talked about this really well, I don't think the goal is make sure we get through all of it. Let's run and hustle. I'll be back again. You'll see me again. I'm gonna go down to strategies to shift the narrative. Again, I keep restating getting the patient as fixed in the frame as possible. That's the point. That is what we're here for. So how do we continue to practice that? One thing that I'll start with is why does this matter? Why do narratives matter? And one statistic that I saw from the Robert Wood Johnson Foundation is that about 50% of our health outcomes is based in right here, living conditions and social drivers of health. It is not risk behaviors, it's not disease states, it's not how much medications and how perfectly we're titrating things, but right here with social drivers of health. So if social drivers of health are definitely impacted by institutions and these root causes of inequity, then it's important for us to look beyond just how we're doing with that medication, that treatment plan, to a broader impact of society and how the social drivers of health are impacting the patient's health. So I just wanted to pan it out again, just to restate my case of why should we care, why this is important. So looking very much inwardly, mitigating unconscious bias, the way that you think about people, the way that you think about Baltimore, whoever you see on the street, and just giving examples, is to be aware of those biases, right? I have an opinion about this. It may not be nice, it may not be right, but this is how I feel about it. How can I address that, right? How can I really examine that bias? Be systematic, right? Don't assume just because, I'm going to tell myself, you think nicely about that person. No, it's probably better to have a plan. With racism, it is a system, right? So we need to be systematic about our anti-racism practice, about our inclusion practices, so that we can counteract those narratives that will continue to swirl around us constantly. You don't want to assume anything, but one thing might be to orient and train everyone, as we're doing today. Develop best practices as a team, whether it be in psychiatry and ambulatory care. Where are the problem points where we might not be giving a very accurate or positive narrative about people? How can we address that? And be open to new experiences, right? Get to know people and their real story. Not I was at Rutgers University and I came down here and I've been a pharmacist and I'm an ID pharmacist. No, the real people behind those, initial kind of hello cards, right? To really get to know people and new experiences, because it helps you to deepen those narratives and messages and maybe correct some of those things. Again, really, this is just a sort of a reminder of what we kind of talked about, really mastering your stories and with bias, using person first, humanizing language, but also using a health equity lens to frame information. And I have a slide there, a great reference is the CDC has a style guide on inclusion. The American Medical Association has a style guide on language and narratives, many examples. But again, it doesn't matter how many examples, but really understanding the principles behind the why we're using these to make sure the person stays in the center. I'll leave this here. This is actually a really good example of a practice that can be done with a team. And I put the reference here, and it's something that's easily accessible, and it's a teaching tool. One thing that I would like to highlight, we didn't have a chance to go through this in depth, and then I will close, is reframing the narrative on health-related risk factors and how we're documenting race and social identities in the medical record. Dr. Quesada touched on this a lot, but a couple of things that, as a reminder, when we're talking about social identifiers, maybe that's a point of discussion for your team to decide, where are we going to put them? Are we going to put them in, not put them in? When is it relevant? When is it not relevant? I think it's worth a discussion, but at the least we can take it from the introduction, right? Most of the time we can take, the race from the introduction, whether, the person identifies as queer, it's irrelevant, right? In the introduction for the most part. And then also when we're reporting issues of race, right, but that we're reporting the patient's experience, right, as a person of color, as an immigrant, and what are the social drivers that is now impacting their health, right? I don't have the opportunity to have insurance, whatever that might be, but reporting the social drivers versus saying race, which really doesn't help to communicate things that are very helpful. So I'm going to leave it at that, and I apologize for running over, and do we have time for a question or two or maybe?
There was no burning questions. We could do like a 5-minute break.
Yeah, and I can,
answer questions during the break.
Oh yeah, that would be great.
Thanks all.
All right, thank you all so much for your attention. I really appreciate it.